the do-it-yourself, novel, safe, and cost-effective diagnostic cubicle for glaucoma practice. No financial disclosure. When COVID-19 happened, we converted the previous glaucoma waiting hall into an OPD and investigation cubicle and brought all the ophthalmic gadgets needed for an eclectic glaucoma setup under a common roof to reduce patient movement inside the hospital premises. This is an image showing the pre-COVID glaucoma waiting hall, which was now converted into a transparent glaucoma diagnostic cubicle where all OPD patients were examined and investigated. It was installed on May 4, 2020. The dimensions of the cubicle were as follows. The length and breadth was 16 feet each and the height was 8 feet with a total area of 256 square feet. This video shows the insides of the cubicle comprising of a slit lamp with applanation tonometer, non-contact tonometer, another slit lamp, confocal fundus capture device, EMR, optical coherence tomography and biometry for working up combined surgery patients. In front of all gadgets, openings were made for patients' head and chin rest during examination, which can be closed with sliders during times of disuse. Customized inward angulated dents were provided for various ophthalmic gadget stations for the comfort of patients' leg positioning during examination. In the upper part of the cubicle, along with the primary acrylic barriers, every machine had a shield installed, yielding a secondary physical barrier between the doctor and the patient. This video shows the cubicle from the outside, highlighting the 3 feet distance between each ophthalmic gadgets and the 3 feet patient seating distance between examinations at various stations, following the social distancing norms for utmost patient safety. Materials used in making the cubicle. When you add acrylic sheet, aluminium beading, jigsaw cutting blade and adhesives, you get the do-it-yourself coronicle, that is the glaucoma diagnostic cubicle for a holistic glaucoma practice. The acrylic sheet thickness is 8 mm. We have used 4 of them. The aluminium beading 2x2 inch, 20 pieces were used. 4x4 inch, 4 pieces were used. Adhesives such as Fevicol was used to fix the cubicle with the floor, and araldite paste was used to fix the cubicle with the ceiling. Along with these materials, we also used jigsaw cutting blade, screws, bolts and nuts. The economics. The acrylic sheet costed approximately Rs 2.25 lakhs. The aluminium beading costed Rs 28,000. The adhesives costed Rs 2,500. Adding to it the cost of screws, nuts and bolts, lock for sliders and door, and air conditioner, it cumulatively costed approximately 3 lakhs. With the inclusion of labor and cutting charges, it can cost up to Rs 3.4 lakhs approximately. The highlight feature of this diagnostic cubicle is that it can be opened and closed with the leg, preventing usage of the hands. Since there is a physical acrylic barrier between the patient and the doctor, 2 microphones and 2 speakers were provided, one for the doctor and one for the patient to establish smooth communication between them. If there is a need for transfer of case sheets from outside to the inside of the cubicle or vice versa, a small horizontal rectangular opening made in the cubicle ensured smooth passage of it. This is a picture showing the clinical workflow from inside the cubicle where fundus photo and OCT are taken for glaucoma evaluation along with lens star and Scheimpflug imaging for cataract workup in the event of planning a combined surgery for IOL power calculation. Another additive feature is the local area network LAN or wireless LAN, which can be used to interconnect all the ophthalmic gadgets holistically so that every patient data will be at the doctor's personal computer. Let us see a working example of a progressive primary open-angle glaucoma patient with LAN interconnectivity, along with simultaneous comparative examination of both the right eye and left eye color fundus images. Features such as red-free filters and zoom can be customized accordingly. Simultaneously, all visual field examination files can be accessed for the same patient from the start till the last follow-up. In this case scenario, depicting a progressive superior arcuate scotoma, telecommunication can also be employed from the cubicle where doctor can access the files from remote areas through TeamViewer or any desk. In this example, the superior notching in the fundus is compared with the superior polar analysis loss of the visual fields respectively. Validation and results. In 16 months, 97.82% of the ocular patient examinations and investigations were performed with gadgets inside the cubicle. Remaining 2.18% only were performed outside the cubicle. Independent t-test compared the data and it was statistically significant. Majoritively, gadgets inside the cubicle were employed in routine practice, with only ultrasound pachymetry and visual fields being examined from outside the cubicle as it required a dark environment. Another problem with visual field examination was the influence of the face mask. When patients enter the hospital, their mask positions are fine, but when they perform perimetry, there is a tendency for them to pull it down during chin rest, causing contamination of the bowl-type perimeter. If they are instructed to correct their mask position, they tend to overcorrect it, causing it to cover the inferior aspect of the pupil, resulting in artifacts. Keeping the incorrect face mask positions in mind, we stick a micropore tape on the mask to prevent mask dislodging or plan virtual reality perimetry, as the nose will be exteriorized in them, and also the VR perimetry results have high correlation with Humphrey perimeter. To conclude, the Chronicle provides state-of-the-art features required for a comprehensive glaucoma evaluation. It has helped instill confidence and safety among medical and paramedical personnel during the pandemic. Practical, do-it-yourself, high-yield glaucoma practice pattern innovations post-COVID-19 pandemic can work wonders in glaucoma diagnostics. Thank you.